much for this privilege. Cardiac transplant in India, how good are the results? We are striving towards it, but we don't have a registry or national data in this country at this point in time. So I will present the results of our own series. Two brief slides. I was listening to a lot of excellent talks before, including from Dr. Shetty. Most of the functional classification of heart failure uses NYHA. For the purpose of heart transplant or LVAD, NYHA we feel is too broad a category because NYHA class 4 could be orthopnea, could be cardiogenic shock. And as we know, the outcomes of any kind of major intervention in these two categories can be very different. So Intermac was introduced in the year 2006, and that's what we have been using to risk stratify the functional class of our patients. And for the postgraduates in the audience, Intermac 1 is cardiogenic shock, where some kind of an intervention is needed in a few hours. Intermac 2 are the typical patients we see in our intensive care units, where every morning you come, their creatinine is rising, the urine output is dropping, and you have to go on increasing the inotrope, so on and so forth. Very broadly, lower Intermac is sicker as compared to higher NYHA class, which is sicker. So this study involved an 8-year period from the year 2012 to March 2020, and we analyzed a total of 257 patients. The youngest was 1 year old, and the oldest was 81 years old. And this is the sex distribution. And we defined hospital mortality as death within 90 days of transplant. So when we did a logistic regression of risk factors for 90-day mortality, a few things were striking. The three most important risk factors for in-hospital mortality was Intermac category with an odds ratio of 0.27. You have to understand that this signifies that lower the Intermac score, higher is the risk of death. That's why the ratio is less than 1 with a p-value of 0.00. Creatinine was again a very important risk factor for death with an odds ratio of 2.16 and a p-value of 0.005. And interestingly, a high right atrial pressure in our series had an odds ratio of 1.07 with a p-value of 0.020. The conventional risk factors of ischemic time of the donor heart and pulmonary vascular resistance did not seem to have very significant risk factors. It could be because then we have a bias towards case selection. If you have a PVR which is prohibitively high, we may not choose them for a transplant. If a PVR is high, we might also choose a donor appropriate to that PVR. For instance, in a PVR of 5, in a 40 or 50 kilogram patient, we might wait and choose a donor who is 90 kilograms and overweight. Or ischemic times of up to 7 hours we have used, but in those cases, we make sure that the organ itself is from a young donor with excellent function. So it does not attain statistical significance. So we'll restrict our discussion to the first three categories. As you can see from this slide, the Intermac distribution in our series, almost 80% of patients were in Intermac 1, 2, or 3, and we're the good, close to 30% of patients were either very sick, Intermac 1 or 2. Similarly, this is a preoperative creatinine distribution, less than 1.2, 1.2 to 1.5, and more than 1.5. The reason I bring this up is creatinine more than 1.5 seems to be a significant risk factor for both early and late death. The overall results, the 90-day mortality was 16%, and roughly around 84% of these patients were alive at the end of 90 days. These are, of course, all comers, including the sick with cardiac arrest, the whole works. So this is our 90-day mortality. And we analyzed them. First, the Intermac had a great influence on 90-day mortality. 34.2% for Intermac 1 and 2 was 9.6% for Intermac 3 and more. So clearly, if the patients were to be referred a little earlier when they're not virtually dying with a blood pressure of 40 and being massaged, they have a much higher probability of surviving the operation and a very significant p-value of 0.000. Again, creatinine had a very significant influence on 90-day mortality. And it's actually graded. Creatinine less than 1.2 had 10.3% versus 21% for a creatinine more than 1.2 to 1.5 and 37.5 for creatinine more than 1.5. Going on, the highest we have done is 6. Again, very significant p-values of 0.000. Interestingly, and this is where our results become interesting, we are historically and conceptually taught and told that poor right ventricular function is a automatic indication for a transplant because they don't do well with a VAD. Interestingly, what we found that right ventricular function does play a role even in survival after transplant. And here in this particular paper I'm presenting, we looked at right atrial pressure less than 15 and more than 15. And we found surprisingly very significant, if the RA pressure was less than 15, the difference between less than 15 and more than 15 was 13.4 versus 22.6 with a p-value of 0.078. Poor outcomes with high RA pressure were seen only in patients who had low systemic afterload, either measured as a low systemic vascular resistance or low arterial elastance. We had when you have a patient with a high LA pressure over a period of time, automatically the left atrial pressure has an impact downstream, and the mean PA pressure goes up and the PVR goes up. So we were wondering whether a similar situation would entail involving the right side. That means when you have a high right atrial pressure, as a consequence, will the systemic vascular resistance be affected? When we analyzed our data, there was very little correlation between SVR and, as you can be seen by the straight line. We thought that it is probably because the calculation of the systemic vascular resistance involves right atrial pressure. So we thought we'll analyze a measure of afterload, which is independent of right atrial pressure, and that is arterial elastance. And you can calculate arterial elastance outside of conductance catheter by the formula I've shown. So we calculated the elastance in all these patients. We found a significant relationship between SVR, RA pressure, and EA. As the EA increases, as the RA pressure increases, the EA increases, or arterial elastance increases. And systemic vascular resistance has a linear relationship with arterial elastance. The effect of high RA pressure on mortality seems to be mediated through end organ dysfunction of liver and kidney. So we started looking at the MEL score. A MEL score of 15 had a very significant differentiation between death and survival. 14.1% for MEL score of under 15 was 27.7% for MEL score of over 15. And this was dictated by EA. And this is, again, margins plot from logistic regression. As you can see, for a given MEL score of even 15, if your systemic vascular resistance or elastance is high, more than 2.8, the probability of death is less than 10% as compared to almost 30% if they are profoundly vasodilated. So I'll come to this later. What about medium-term survival of up to 8 years? For the overall series, we had about 65% survival of the longest follow-up we have now is 8 years. So our Kaplan-Meier curve for 7 year, 8 year, up to 18 months is roughly around 65%. There seems to be a difference between pediatric and adult transplants. Patients under the age of 18 had a significantly better survival at 7 years or 8 years with a p-value of 0.356, almost 74% 7-year survival as compared to older patients. The most significant effect on long-term survival is Intermacs. Again, as you can see, Intermacs 1 and 2 had poorer results, but these are all essentially early mortality. If you survive 1 year, the late effects seem to be not much significant. Creatinine continued to have an effect long-term despite early outcomes. And again, we divided creatinine category into 3, less than 1.2, 1.2 to 1.5, and more than 1.5. Creatinine more than 1.5 had significantly poorer outcomes with about 50% survival at 7 years as compared to close to 75% of the renal function was adequate. And interestingly, this was related to the age of the patient. If the age was less than 30, there's very little impact of creatinine on long-term survival. If the age was between 30 and 40, the impact of creatinine is more and is maximum beyond the age of 50. So clearly, older patients with high creatinine tend to do poorly despite transplantation. Poor long-term outcomes were seen with high RA pressure. Again, I was surprised when we found that even after transplanting with a high RA pressure for whatever reason, the effect was seen right up to 5-6 years, but only if the preoperative systemic vascular resistance was very low or afterload was low. So for an unstratified number of patients, if the RA pressure was less than 15 or more than 15, with a log rank of 0.0059. There is a significant difference between if the RA pressure was less than 15, you're close to 70% 7 years survival as compared to 50% if the RA pressure was more than 15. But in these patients, if the preoperative elastance or SVR was very low, the difference is striking, as opposed to if the preoperative elastance or SVR was high, there was no difference in regard if the RA pressure was high or low. So clearly, the effect of right atrial pressure on survival was dictated by organ perfusion pressure. Same thing was seen with MEL score. A MEL score of less than and more than 20 had a significant difference in 7-year survival, but not if the systemic vascular resistance was significantly elevated as compared to otherwise. So we looked at the reason for this difference, and we found that the reason the high RA pressure seems to affect mortality is through organ perfusion pressure. That means if you have a CP of 25, if you have a mean pressure of 60, the perfusion pressure of your kidneys and liver is very low. So what is the optimal organ perfusion pressure at which the organs are safe? We didn't find a number which was significant for pure organ perfusion pressure. That means mean arterial pressure minus CVP. But when we indexed it to the body surface area, and we called it organ perfusion pressure index, we found that organ perfusion pressure index of less than 40 and more than 40, which is the median value in our series, very significantly stratified outcomes. As you can see, the p-value of 0.012, close to 74% 7-year survival as compared to 50 odd with organ perfusion pressure less than 40. Again, so this is a manifestation of some type of cardiorenal syndrome. Here, the effect of RA pressure is more important, because if the RA pressure was less than 15, the effect was not seen. So finally, last 3 slides. On the basis of a Cox proportional hazard regression, when we analyze the whole group, the best outcomes in patients with poor RV function were seen in patients with a right atrial pressure which is less than 15, with the normal systemic vascular resistance of more than 1500 Wood units, or EA more than 2.7, and organ perfusion pressure index more than 40. Their 7-year survival was in excess of 80%. The worst outcomes were seen in patients with RA pressure more than 15 with low systemic vascular resistance and organ perfusion pressure index of less than 40. So in these patients, if you were to improve the organ perfusion pressure index by either an IABP or other means, you can improve their outcome. And one of the things is, a lot of these patients come to us because of multiple drug therapy trying to lower their vascular resistance or afterload in order for the heart failure to be treated. And that strategy works just fine if it's isolated left ventricular dysfunction. But when they have very significant RV dysfunction with a CVP of 25 or 30, lowering the blood pressure to levels which impact organ perfusion pressure can lead to very deleterious long-term consequences, and the effect seems to persist for up to 7 years. So patients with high blood pressure need a higher mean blood pressure. And on the basis of this is the last slide. So because the current COVID scenario, the number of organs, donor organs is very limited. So again, based on our Cox proportional hazard regression, this is our current algorithm for allotting patients for either a VAD or a transplant. If your Intermac category more than 3 or equal to 3, that means you're a stable patient with a normal renal function, creatinine less than 1.5. If the PVR is okay, regardless of RV function, a transplant is the best option because their survival is likely to be almost 80 to 85% at 7 years. On the other hand, if your creatinine is 1.5 or more with poor renal function, especially if you're more than the age of 40, you're probably better off with a VAD because your long-term results of transplant are not great at this point in time. So in between is a good patient with good RV, creatinine less than 1.5, but those who are Intermax 2 or 3 sliding to 2 because they're waiting for an organ, with the current availability of HeartMate 3, they're probably better off with a VAD. So what about functional outcomes? Excellent functional outcomes are possible. This patient was airlifted from another city. I think one of the cardiologists in the panel might remember him. Renal failure, sepsis, was transplanted 5 years ago. He's now a CEO of a 2,000 crore company, and this advertisement came in the Hindu yesterday. So very gratifying to see someone airlifted on IABP renal failure, sepsis, about to go on ECMO, doing so well after 5 years functionally. And this man has finished 5 years post-transplant, finished a first and half marathon. Some of these results have been published in the Indian Heart Journal, is available open access had published ahead of print in their website. And so in conclusion, excellent outcomes are possible with heart transplant in appropriately selected patients, and early referral is important for good outcomes. Thank you very much. I'll be happy to take any questions.